So first of all, again, thank you so much for this lecture, for giving me this opportunity. And thank you again for making it after the Chelsea FA Cup match, so that I have time to see the match and see Chelsea win. If we have any Man City fans, they're going to miss their match. Anyway, so diverticular disease. As Dr. Ali said, I'm Suliman Almazeedi. I proudly graduated from the Kuwaiti Board of Surgery. And then I went on to do 2 fellowships. So I have dual fellowships, one in upper GI, benign upper GI and bariatric surgery from Chelsea Westminster Hospital, and the other in colorectal surgery from the Royal Marsden Hospital, both in London. So something interesting, to make this lecture interesting, what I'm going to do is throughout the talk, I'm going to give you 3 stories of famous people who had or suffered from diverticular disease, how it affected them, and what lessons we can learn from the experience they had. So I'm not sure if any of the audience are as old as me, but there's a group that was well known called Van Halen. So this group, they had a tour in Japan, 2012. If you can see, this is the page of their original ad, dated, I can't use my mouse, but it's dated June 15, 2012, if you can see on top. And it says that the plan was November 20 through to November 27, they would have a tour in Japan. So remember those dates, November 20 to November 27. What happened was, this is the article from the actual Japanese newspapers. It says here that they had their actual show June 18th, 2013. So it happened, there was a delay of around 8 full months from the time the plan of the show was to when it actually happened. The reason was their lead singer, Eddie Van Halen, had diverticulitis during the tour. So as soon as they landed in Japan, he got the attack and they had to delay everything for 8 full months. So the lesson, you should always have an exit strategy. Eddie Van Halen, had signed a paper with the touring company that in case something happens, they can delay without him losing money. So everyone should have an exit strategy in case they get diverticulitis or anything else, to have an exit. So diverticular disease, this is what we'll talk about today. We're going to go through these quite quickly. Some of them are interesting, some of them unfortunately are boring. So first we're going to talk about the anatomy and the pathogenesis. We'll talk about some risk factors, the epidemiology, some of the complications, specifically those related to diverticulitis. So I put some numbers here, just so that you know along the way, if a patient gets diverticulitis, the 4 different complications they can get with their percentages. And then we'll talk briefly about bleeding, and we'll talk about the guidelines from the 3 main surgical bodies regarding management of diverticular disease. Now, diverticular disease is a very hot topic because the management keeps on changing. And I think this is one of the main reasons we're giving this topic. It's a common disease, but as most of you know, the treatment algorithms are always changing. Every single conference the surgical conference that happens these days, there's someone standing up and talking about some research that dramatically changes the way we treat the disease. So that's why today I will cover the main surgical bodies and what the agreed upon guidelines are. I won't talk about specific studies and what they suggest. We'll talk about guidelines. So the basics. This is a diverticula. As you can see, it's a sac-like protrusion. What happens is, this is the colonic wall. I'm talking specifically about colonic diverticula here. Areas where the vasa recta, so the blood vessels, go through the inner circular muscles, are weak points, because there's a weak point in the muscle layer. And this is where, because of high pressure, we get what we call a diverticulum. Now, these diverticulum we call false. We refer to them as false because not all layers of the bowel wall come out, as you can see by this diagram. So the muscles are still intact. There's mostly mucosa and submucosa, and of course the serosa. So why does it happen? Why do people get diverticular disease? So there are many theories. No one knows why yet. But basically, the main idea is there's abnormal motility in the colon. This is related to diet, Western diet, low in fiber, as well as a genetic predisposition. This causes an increase in intraluminal pressure. And of course, when there's an increase in pressure, the mucosa and submucosa herniate through that defect in the muscle. What causes that motility? It's still unclear. The main theory that is in the scientific field today is an upregulation in the smooth muscle M3 receptors, which you can see in the diagram. Do not ask me about the diagram. It is a very confusing diagram, and this is why we're all surgeons and not biochemists. So, anatomy. So this is basic anatomy of the colon. As you know, diverticular disease can occur anywhere in the colon. Most commonly in the developed world or in the Western world, they usually happen on the left side, in the sigmoid. However, they can happen in the right side, especially in Asian countries. They usually happen on the right side. Why that happens, nobody knows. The theory to why diverticular disease occurs more commonly on the left side is related to the law in physics, the Laplace law. As most of you know, pressure equals tension divided by diameter. So if you have a decrease in diameter, as in the sigmoid colon, you will end up having higher pressure and more tension, causing more diverticular disease. So as we said, most of them are in the sigmoid colon. However, it is race dependent. So there are very large population studies looking at diverticular disease prevalence. So right-sided was actually found to be patients who do have right-sided disease in developed countries. There's a higher chance that the blacks in that community will have it compared to the whites. We're talking about right-sided disease. In addition, Asians, as we said, have predominantly right-sided disease, especially in Japan. So risk factors. So as we know, there's a very big study, and I cited it. Most of the information here is from up-to-date. The information that isn't from up-to-date, I'll cite. So a big study published 2017, 51,000 men aged 40 to 75, 900 cases of diverticulitis. The factors, the main factors, and this is well agreed upon in most societies. High intake of red meat is a very strong risk factor for developing diverticular disease. And as you can see on the right side here, I have a picture of a very delicious steak. I'd like to point out that this is cooked medium, and nobody should cook steaks, I think, more than medium, or you're it's very humiliating for the steak if you cook it more than that. Low dietary fiber, as we said, lack of physical activity. So all of these factors were found to be statistically significant with increased incidence of diverticulitis. High BMI, more than 25. So people who are overweight and obese, and of course, smoking. One important thing that I do have to mention is classically, especially if some of us have consultants in our units who are of the older generation, classically it was thought that seeds and nuts predisposed to diverticulitis because the seeds or nuts can actually, it was thought that they get inside the diverticula and can cause obstruction of the diverticula itself and subsequent diverticulitis. However, there is absolutely no evidence for this. In fact, popcorn, as you can see in the picture, was found to have an overall protective effect from diverticular disease. So, other factors. So these are based on small studies. There's not a large amount of evidence on these, but it is generally observed that NSAIDs, steroids, and opiates increase diverticulitis and diverticular bleeding because NSAIDs, of course, alter the coagulation. Statins reduce diverticular perforation. Again, this is based on a few small studies. Increase in vitamin D, the wonder vitamin that everyone keeps talking about, is found to reduce hospitalization for diverticulitis. And then there's a few disorders, some very rare ones like Williams-Boren. I've never heard of it actually before. Chemotherapy and HIV can actually increase diverticulitis. We'll talk about epidemiology next. I just don't know how to remove my video from the screen, but anyway. So as we know, it is very age dependent. One of the questions was related to this in the beginning. So the prevalence is actually increases with age. It's as low as 20% by the age of 40, but can go up to 60% at the age of 60. Now this statistic I think is very important. And I usually quote it to patients when you see them, especially for the residents, when you have patients who have no idea what diverticulitis is, you can always reassure them and give them the statistic. It's very easy to remember. 60% at age 60 have diverticulosis. Diverticulitis, specifically, the mean age for developing it is around 63. So it's a disease of older age. However, there has been a dramatic increase in young people getting diverticulitis. From 1998 to 2005, there was an 82% of the increase in incidence was in the age 18 to 44 years. So we're seeing a very, very sharp increase, very similar to colon cancer in the younger age groups. So we'll go to the next story now, just to keep things interesting. I'm sure most of you know who this is. Most of you are young, but this guy is a hero of the century. This is Fidel Castro. I'm not a communist, but this guy is very well known to have led the reconquering of Cuba. Most of you also know that, I hope most of you know, that he was very close to death in 2006. So no one really knows what happened, or no one knew what happened initially, but there was a cable from the US Embassy on WikiLeaks that actually told us, and all of you can access this. I actually accessed it myself. If you search WikiLeaks and you go and look at Castro, write diverticular disease, you'll get this. So in 2007, this was from the US Embassy. Of course, there's no US Embassy in Cuba, but they operate from the Swiss Embassy there. So they say that he actually had a perforation. Now there's controversy over where he had it. Some people say it was in London. Some people say it was during his trip to Spain. Basically, as you can see here, so he had a perforation in large intestine. He needed a colostomy, which he refused. So he had surgery done, and he had primary anastomosis. He refused the colostomy, as we said. He then had a complication, and then he had a fistula as well, which made him lose a lot of weight, 40 pounds approximately. And this is the guy who did his surgery. He's a Spanish surgeon, Dr. Garcia Sabrido. And he's the person who had the surgery done. So what's the lesson learned? You can be a great man and lead the biggest revolution in history, but something as small as a 1 millimeter diverticula can bring you down to the ground. So size matters, be careful. Next, we'll go to the clinical aspects. So we talked about the basics and the basic information regarding diverticular disease. Now we'll talk about the natural history of diverticulosis. So this is important as well, because this was one of the questions. So diverticulosis, people who get it, 70 to 80% are completely asymptomatic. And this is very important to remember, because it's not a disease that we should screen randomly and treat randomly. Diverticular bleeding happens in 5 to 15% of people, and diverticulitis occurs in just 4%. in the majority of these patients, it is a simple attack, and most of them are treated without further intervention. So very simple. In the complicated diverticulitis, and this is what we talked about in the beginning, more than half of them, around half of them, get an abscess, and then the rest either have obstruction, and this obstruction is usually due to either the abscess obstructing the lumen, or from chronic inflammation, which causes fibrosis. And then the rarer complications of perforation and subsequent fistulation. So this is very simple. I mean, even medical students know this, but it's important to say these presenting symptoms, if a patient has them, should make the clinician think or suspect diverticulitis. Why did I mention these? Now, even though these are simple, you do have to know that in some countries, in some guidelines, a lot of doctors don't have the facilities that we have in Kuwait. I know a lot of us aren't from Kuwait, and it depends from country to country. But in Kuwait, mostly if we get a patient with left lower quadrant pain, symptoms like these, we directly send them to get a CAT scan, a CT scan. In a lot of places around the world, you don't have to do this. It is actually a waste of resources, because if you have all these symptoms, there's a very high probability that this patient has diverticular disease or diverticulitis. So left lower quadrant pain, the other name for diverticular pain is left-sided appendicitis. And if any of you have seen, I'm sure most of you have seen patients with diverticulitis in the emergency room. They present exactly like appendicitis, but the pain is just on the left side. Nausea and vomiting aren't very common, but they can occur. Low-grade fever, palpable mass in 20% of the patients, especially if there's omentum around the inflammation. Change in bowel habits, most of the time it's constipation, as we said, as decrease in fiber intake and increased diverticular disease. Urinary symptoms, even without a fistula, can occur in 10% of patients because of the very close proximity of the sigmoid colon and the inflammation to the urinary bladder. So it is actually 1 out of every 10 patients will present with urinary symptoms without fistulation. So if you had only one blood test to do, this should have been a question, Dr. Ali, we should have asked this, but if you had only one lab test to do for a patient suspected to have diverticulitis, it is CRP. All of the guidelines from the major surgical bodies agree to this. So CRP, generally above 50 milligram per deciliter, points towards, of course, it is not specific, however, it is quite sensitive for diagnosing diverticulitis. Usually they only have mild leukocytosis, mild elevations of amylase and lipase, and the urine, you can have either one of two things, either sterile pyuria, as we said, due to adjacent inflammation, or if there's a fistula, you'll find colonic flora on a culture, if you do a urine culture. And this is highly suggestive of colovesical fistula. So you get a patient and you suspect that they have diverticulitis. We're going to talk later about how to stratify patients and to decide which patients need further investigation and which patients don't. But when we talk about the next step, so we did the lab investigations and then we talk about radiology. So the single best test you can do to diagnose diverticulitis and to rule out the complications is a CT scan. Now, it has a very high sensitivity and specificity, as you can see, very specific, 99%. We'll see in the next slide an example, but the findings, basically, you have the triad of a presence of colonic diverticula, of course, localized bowel thickening, usually more than 4 millimeters, and fast striding. If you see these, it is most likely diverticulitis. In addition to these, you can also detect the complications such as an abscess, obstruction, or fistula. So a CT scan is very, very useful. This is an example. I wish I had my mouse, but I can't really show. But anyway, so the arrows without the line, so just the arrowheads, are pointing at diverticula. So you can see them outpouchings with some air. And then the arrow with the line, not the dashed line, the normal line, is fat stranding. So you can see fat stranding. Usually you can even have some omentum, but in this case it's not. And then the arrow with the dashed line is pointing towards the sigmoid mesentery, and you can see that the mesentery is thickened. So there's thickening of the mesentery as well. So it's a very clear picture here, and I think it's very important, especially for the residents, to learn how to read images, especially CT scans. So other methods, radiological methods, we have a simple chest X-ray to rule out air under diaphragm. Of course, it's very rare. It only happens in 3 to 12% of cases, but you can also detect obstruction. And ultrasound. Now, this is something very new. High-resolution ultrasounds actually have results, sensitivity and specificity comparable to CT scan. They can also detect abscesses and they can localize them. However, as all of you know, ultrasound is very operator dependent. I'm not really sure how many radiologists in Kuwait or around the world have experience. I know there's 1 or 2 GI doctors in Kuwait who have experience using ultrasounds, but I'm not sure if the machine is readily available in all the hospitals. So I wouldn't ask for an ultrasound if I was in my practice in Kuwait. MRIs, they are equally good to CT scans, of course. The only issue is that they take a lot more time and are a lot more expensive. The advantage is, of course, there's no radiation. So again, if you had to choose to do a radiological modality, choose CT scans. Okay, so this brings us to the next topic, is how do we stage the severity of the disease? So we've seen the patient, we've taken the history, we've done the labs, we've ordered the CT scan, we've seen the result. Now, how do we stage how bad his or her situation is? So Hinchey, Edward Hinchey, you can see his picture there. He looks like a very nice man. I haven't met him before. They say he's still alive, by the way. He's one of the few great surgeons who's still alive, and I think he still works in McGill in Montreal. I don't know if at the end of the session, if we have any listeners from Montreal, they can tell us if he's still there. But I know he's still alive, that's for sure. So he came up with a classification for diverticulitis. So this is, the Hinchey classification is for complicated diverticulitis. Okay, it's not for simple diverticulitis. So it's for abscesses or perforations. This is his original classification, published, I believe, sometime in the late 70s or early 80s, I'm not sure. So stage 1, as you can see in the picture, it's a pericolic abscess. So right near the colon, there's a small abscess that's confined, it's contained, and that's it. Stage 2, it's an abscess that's contained. However, it's extending all the way down to the pelvis. Stage 3 is where these contained abscesses rupture. And so you have suppurative peritonitis, but no feces. And stage 4 is when you have feculent discharge in the abdomen. So Schur et al. Came up with the modified Hinchey classification, and this is the one that's currently being used by most colorectal bodies. So stage 1 is the same, more or less. Stage 2, they've divided now into distant abscesses that are amenable to percutaneous drainage. And stage 2B is complex abscesses associated with fistulas. And then stage 3 is the same thing, more or less, and stage 4 is the same. So they just divided stage 2. So the clinical course. Before we talk about the management of diverticulitis, which is the bulk of this talk, we'll talk about what happens to patients usually. So in acute, uncomplicated diverticulitis, so no Hinchey, conservative management alone, and we'll talk about what this conservative treatment is usually successful in the vast majority of patients. 30% of these, they will remain asymptomatic. 20 to 50% will have recurrent attacks. However, and this is, I know most of you know this already because everybody keeps saying it. However, these recurrent attacks are usually not of higher risk of complications compared to the first attack. So usually if someone has an attack of uncomplicated diverticulitis, even if they get subsequent attacks, usually they are not of a more advanced stage than the first attack. And this is the main reason why a lot of the guidelines have been changing recently. In the past, it's always been thought that younger patients should definitely undergo resection. The main reason being that in the future, even if their initial attack was simple, in the future they will get more severe attacks. They have a lot of years left ahead of them, so better to chop their colon. This, however, is changing. And as you can see, we'll talk about later, the different management guidelines is changing the way we treat patients. So mortality of diverticulitis is approximately, it's not very high, it's 0.6 to 5%. However, in patients with a perforated diverticulitis or purulent or fecal peritonitis, it can be up to 20%. As you can see, the picture on the right, you know when you open an abdomen and you see this, it's going to be a long night and it's going to be a sleepless on call. And unfortunately, you'll have to know that this patient has up to 20% chance of not surviving the admission. Okay, so management. There's so many surgical bodies with different management protocols for diverticulitis or diverticular disease in general. I chose the three main ones that are used as reference around the world. So we've got the Americans, who have the American Society of Colon and Rectal Surgeons, the ASCARs. Their guidelines were actually just released. So June, this month, they released their new guidelines. So it's good that we have a chance to talk about them today. And then on the other side of the Atlantic, we have the Europeans, the European Association of Endoscopic Surgeons, the EAES, which is basically the European branch of SAGES, the American Society, the Society of American Gastrointestinal Endoscopic Surgeons. So they came up with guidelines last year, 2019. And then the UK, the National Institute for Health and Care Excellence, NICE, they released guidelines in November 2019. Now, the major differences you'll see is between the Americans and the Europeans is how conservative they go. Usually, Americans are very trigger happy. They like to cut, and you'll see the differences now in the guidelines. The British, the NICE guidelines, you'll see focuses a lot more on antibiotics, and we'll talk about it now. So these guidelines, I know there's a lot of text, but we have to talk about these in detail. Now, these guidelines, they're very, very, very long documents. Okay, they're pages upon pages of recommendations and guidelines. Basically, what I did is I took the statements that are most relevant to us and the statements that all have very strong level of evidence and strength of recommendation. Okay, so I chose I chose very few, even though it'll seem like it's a lot, but I chose the ones with the strongest evidence and the most relevant. Okay, so the Americans, ASCARs. So these are statements directly from their guidelines. Selected patients with uncomplicated diverticulitis can be treated without antibiotics. And this is the big change now. You'll see that all three guidelines agree to this, that selected patients, and again, they're very careful here, medico-legally. They say selected patients. Usually it's younger patients with no immunocompromise, with very simple diverticulitis, no major changes, no major, of course, completely stable. These patients, not only can they be managed outside the hospital, they can be managed without antibiotics. This is a very big jump in the way we treat diverticulitis. And again, most of these guidelines refer, I know I'm not going to talk about specific studies because there's a lot of conflict, but they basically refer to the Diabolo study that looked into this. Number two, non-operative treatment of diverticulitis may include antibiotics. So if patients need antibiotics, we can treat them with antibiotics. Very straightforward. The difference between the different guidelines with abscess drainage is the size. So the Americans say if the abscess is more than 3 centimeters in size, they recommend image-guided percutaneous drainage. And again, this is a point for the residents. Not every abscess is amenable for drainage. You shouldn't be calling the radiologist for every single abscess you see. We need to base all our decisions on guidelines. So after resolution of an episode of acute complicated diverticulitis, again, this is where the difference is between the Americans and the Europeans. The Americans advise all patients should have a colonoscopy after resolution. And again, this is typically 6 weeks afterwards. And this is because one of the major differential diagnoses for diverticulitis is colon cancer, as most of you know. So the only people exempt from this are people who recently had a colonoscopy, of course, before the attack. So after successful non-operative treatment of diverticular abscess, I can't see because my videos, I can't read all of it, but elective resection should typically be considered. Again, so complicated diverticular abscesses, we should resect afterwards. Elective colectomy should typically be recommended on patients with diverticulitis complicated by fistula, obstruction, or stricture. So as I said, the Americans, they like to chop. Elective resection based on young age is not recommended. And again, this is a huge difference from what we were typically taught a long time ago. Typically, we were taught that patients younger than 40 with an attack of diverticulitis should have an elective resection because he or she have a long life ahead of them, and it's better to get their colon out before they get more attacks. This, however, is changing, and as you can see by these recommendations, it is no longer recommended. It is more case-by-case, a decision that's case-by-case. So the decision to recommend elective sigmoid colectomy after recovery should be individualized. And I think this is very important. It is very important we talk to the patients and we collectively agree on a treatment strategy. It is no longer simply the decision of a surgeon. So following resection, the decision to restore bowel continuity, so basically to anastomose or not to anastomose or just to do a Hartmann's, is based on many factors, as they say. In patients with purulent peritonitis, colectomy, so this is Hinchey 3 basically. So the biggest controversy now is laparoscopic lavage versus colectomy. So the Europeans, especially the British, they go for laparoscopic lavage. It is basically going in keyhole, cleaning up all of the pus, putting large drains, and basically not doing any formal resection. So they say in patients with Hinchey 3, basically, colectomy is preferred over laparoscopic lavage, as lavage is associated with a higher rate of secondary intervention in comparison with colectomy. And again, this depends on what evidence you see. So the extent of resection, and this is the same in all the guidelines you will see. Basically, you remove the colon, the sigmoid colon, until the margins are healthy. You do not need to go until an area with no diverticulosis, because usually you will find diverticula throughout. So you look at the disease segment, you chop it off, you do the anastomosis, and usually your distal resection margin will be the rectosigmoid junction. So just at the brim of the pelvic brim, you staple there, and then you staple proximally to where the colon you feel by your hand or laparoscopically you feel is not thickened or diseased. So when expertise is available, an MIS approach obviously is preferred to colectomy. And there's a lot of talk these days about incorporating robotic surgery. So I don't know around the world, our guests from around, our participants from around the world, I don't know how available robotic surgical platforms are available in your centers. However, in Kuwait, if you ever decide to visit Jabir Hospital, we actually have done robotic colectomy cases, and we'll be more than happy to have any residents join us on any cases in the future after this pandemic. So now we go to the Europeans. So the SAGES and the EAES, it's mostly EAES. What they say is a trial of non-antibiotic therapy can be considered. So again, as the Americans say, in patients who are immunocompetent and who have uncomplicated acute diverticulitis. So you don't even need to give them antibiotics. You just need to observe them without even an admission to the hospital. Immunocompetent individuals presenting with uncomplicated diverticulitis and mild symptoms, again, they can be managed in the outpatient. They don't need to be admitted necessarily. So this is the difference between the European guidelines and the Americans. So they recommend against routine colonoscopy after successfully treating uncomplicated acute diverticulitis, unless high-risk features are present. So symptoms or features of colonic cancer, or if it's a very old age in a patient who's never had a colonoscopy, obviously. But the Europeans don't advise on mass colonoscopies for everyone post uncomplicated diverticulitis. So for abscesses, so any hinges, they recommend antibiotics, first line treatment. Percutaneous drainage is considered for larger abscesses. Their definition here, EAS definition, is more than 4 centimeters. So compared to the ASCARs, who said 3 centimeters, here it's 4 centimeters. Or in the presence of patient deterioration. So a patient comes in with an abscess, you give them antibiotics, they don't improve, you go for drainage, or if it's more than 4 centimeters in this case. So in stable patients with free air, they don't recommend operative management initially. So a patient comes in, pulse is fine, maybe a low-grade fever, abdomen isn't rigid, but on X-ray there's free air, or even on CT scan, you treat the patient, you don't treat the CT scan, okay? If they're completely stable, you admit them, you give them antibiotics, whatever, but initially they don't need to go for operation. And then in immunosuppressed patients with complicated diverticulitis, they recommend early elective resection. And then they go to the different hinges. So, the Europeans, after a single episode of Hinchi 1 or 2, they don't routinely offer elective surgery, okay? Because as we said, if your initial attack was a low Hinchi, most likely your subsequent attacks might well likely be low Hinchis as well. So lavage, like we talked about, laparoscopic lavage, can be considered in Hinchi 3, exactly like the Americans, with appropriate expertise. The Europeans here, they say that they are almost equal, so they can be considered. The Americans actually, they actually advised against it. So they said that resection is better than lavage. The Europeans say as long as that you watch them and manage them, they should be fine. Again, based on specific patients. When there is a Hinchi 3 or 4, acute surgery should be considered. So you should keep in the back of your mind. Patient comes with Hinchi 3 or 4, there's a very high chance that they're going to need surgery, obviously. So patients with perforated diverticulitis with diffused peritonitis, if you feel they have diffused peritonitis, emergency surgery straight away. When you take them to surgery, they recommend you start laparoscopically. And I think as colorectal surgeons, I speak humbly. I mean, I'm not as well trained as the other colorectal surgeons in Kuwait, but I can tell you that these days, if you have a surgeon that starts straight by laparotomy, and in a case that's stable at least, you should always try with laparoscopy. It's much better for patients. Of course, in unstable patients, that's something else. So in the appropriate clinical setting, they recommend consideration of sigmoid resection with primary anastomosis and proximal diversion over Hartmann's procedure. So again, this is an area of a lot of debate. Now you go in and you see there's purulent or fecal peritonitis. You remove the disease segment. What do you do next? Do you just bring it out as a stoma and do a Hartmann's procedure? For those of you who've operated on Hartmann procedure reversals, all of you know that it is one of the ugliest surgeries you can do. Things can really go south in a reversal of Hartmann's. You can end up damaging a lot of structures. So what they advise here is that you anastomose, but then you bring out a proximal stoma, either a diverting colostomy or an ileostomy, which can then be reversed after you make sure that the anastomosis has healed by a barium enema or colonoscopy. So in hemodynamically unstable patients, if you have a patient, perforated diverticulitis, hemodynamically unstable, just go for Hartmann's. There's no need to flex your muscles. There's no need to prove anything to anyone. Do what's in the best interest of the patient. You're not there to do any fancy surgeries. You're there to save their lives. So in the setting of an emergency Hartmann's procedure, they recommend limiting the resection to the involved segment. So no mobilizing of the splenic flexure unless it's really necessary to bring out the stoma, but basically do the minimum select damage control. Every effort should be made to construct an anastomosis in the elective setting for complicated, uncomplicated diverticulitis. So if you're doing an elective surgery, there's very little justification for you to do a Hartmann's procedure. You should try to anastomose as much as you can. If you feel like your anastomosis is not 100%, or if there's significant compromise, just bring out a proximal stoma. It's very protective. You bring out the stoma, you wait for a few months, you make sure the anastomosis is healed, and then in a very quick procedure, you can simply reverse the stoma. So again, this is very similar to the Americans. You go proximally to where the phlegmon area, the area of inflammation is, there's no evidence of that. And you should not try to resect all of the diverticular proximal because you're going to keep on going and going and finding more. Distal resection, we said sacral promontory. So there's rectosigmoid junction, very easy to staple there. And they recommended elective resection in patients with symptomatic disease that is negatively impacting quality of life. And this, I think, is the most important statement in these guidelines, is when we sit with a patient and discuss whether or not to resect. So patients have diverticular disease. As we said, if they get Hinchy 1 or 2, most likely their next attacks will be Hinchy 1 or 2. So then we need to sit down and discuss with the patients, especially if they're young. How much is this affecting their quality of life? If they say that, and again, this has to be discussed with the patient and through a multidisciplinary team. It's not simply the decision of the surgeon. If they feel like this is negatively affecting their income, their family life, how they can live, if they're athletes, for example, then you think about resection. If not, and they're willing to live with it, getting attacks every 6 months or whatever, being treated with or without antibiotics, you're very valid to follow that decision. Okay, so finally, the British, so they don't go into as much detail, operative detail, as the Americans and Europeans. They base their guidelines more on antibiotics. For those of you who've worked in the UK, you know that they love antibiotics. They love them too much, actually. It's scary how much they love them. Half of their guidelines were about antibiotics. So for people with acute diverticulitis who are systemically well, so uncomplicated diverticulitis, consider no antibiotic prescribing strategy. Again, see now this is the third major surgical body or healthcare body guidelines. These aren't simple studies. These are guidelines. They're saying for simple, acute, uncomplicated diverticulitis, you may consider a no antibiotic prescribing strategy. Give them paracetamol and advise to represent if they get worse. Oral antibiotics are given if the patient is systemically unwell, let's say if there's fever or high CRP, or if there's any other reason why this patient should be thought to have complicated diverticulitis. If the patient is immunosuppressed as well, or if they have significant comorbidities, and IV antibiotics are given to admitted patients with suspected complicated acute diverticulitis. So a lot of the guidelines don't specifically talk about which antibiotics to give. The British do, and I think it's very important to talk about these because in Kuwait, our practice generally has been patient has a CT scan, acute diverticulitis, admit, give Cipro and metronidazole, ciproflagyl. This is what everybody's been taught. However, this, of course, it depends from hospital to hospital. I'm not saying that the NICE guidelines should be applied all over the world, but if we can, I think each individual hospital should have a meeting with their microbiologists and discuss what the best treatment is. I don't think we should be shooting with guns as big as ciprofloxacin. It's a very, very strong antibiotic, and it can have a lot of complications, especially with older people who are people typically having diverticular disease. It can cause very serious musculoskeletal and nervous system damage. So I think we should choose it. As you can see here, it's the last choice. So the first choice for oral antibiotics. So a patient with uncomplicated diverticulitis, but you feel like they might need antibiotics. So you give them coamoxiclav, Augmentin. It's widely available. In Kuwait, you can get it without a prescription. It's a very easy medication to take, very simple, with not a lot of side effects. And then if for some reason you cannot give the coamoxiclav, if there's a penicillin allergy, you can give Kefalaxin, which is Keflex. I believe it's an oral antibiotic. It's rarely available in Kuwait, with metronidazole. And then the last thing you can give is ciprofloxacin. And usually they give it to patients who were previously admitted with IV ciprofloxacin. So IV, so for admitted patients who require IV, so they have complicated acute diverticulitis, so Hinchi 1 through 4, they advise to give IV Augmentin, which again is available in Kuwait. If not, then you can give the Cefuroxim, which is Zinasef, I believe. Again, it's available in Kuwait with metronidazole. And then again, the last line of defense is ciprofloxacin and metronidazole. Again, I do have to point out that this is the NICE guidelines. You cannot change your hospital protocol based on this. This is for NHS hospitals. You need to sit down with a microbiologist and have a proper MDT discussion with them. Tell them what you think and come up with a policy for your hospital. I hope that one day, I'm not sure if the Ministry of Health in Kuwait is doing a national antibiotic policy. There might be one already. I know when I was in Amiri, they used to have one. I think there should be a national policy. But for the time being, you need to follow your local hospital's policy. If you want to change it, you sit down with the correct people and get it changed the right way. So what they say as well, similar to the Americans, percutaneous drainage or surgery if it's more than 3 centimeters. So I think in general, for most residents, if you see an abscess more than 3 centimeters, speak to the interventional radiologist if the patient is stable. Again, the British, they say either offer laparoscopic lavage or resection, depending on the risk and benefits of the two options with the patient. So this is patient Hinchi 3 mostly. If fecal peritonitis is identified intraoperative, so let's say you consent the patient for a laparoscopic lavage versus a resection, and you're thinking it's a Hinchi 3, you go in and you find fecal peritonitis. For the British, there's no role for laparoscopic lavage. You go straight to resection and get that colon out. So my advice, after all these guidelines, for the residents and the surgeons in training, if you have a patient, even if it's uncomplicated diverticulitis, I would advise just in case you don't miss anything. Again, the guidelines, they're conflicting regarding this. So if you do a colonoscopy, you're correct. If you don't do it, you need to justify why you didn't do it. But for me as a surgeon, I'm a very safe surgeon. I would rather do a colonoscopy and it being normal than missing cancer or something else on colonoscopy. And again, you have to wait until the inflammation subsides because of the risk of perforation. So the agreed upon is 6 weeks. So moving on, we've finished diverticulitis. We've spoken about the presentation, the investigation, what to look out for, the management. I know the management was very heavy. It's a lot of information, but I wanted to show you to all the people the different guidelines. They agree on most things, and I think that's the main point. That we don't need to admit every single diverticulitis. We need to risk stratify patients. Patients with uncomplicated disease, patients with minimal complications, patients with moderate to severe complications. We need to start dividing patients up and giving them the right treatment so that we can conserve resources. So bleeding. Cumulative incidence, it increases over time of how long a patient has had diverticulosis for. So increases from less than 1% at 1 year to around 10% at 10 years. Risk factors, obviously, age, as you can see by the incidence, it's higher in those aged more than 70. It's higher in patients with bilateral diverticulosis and obesity. So obesity increases the rate of bleeding, increases the incidence of diverticulosis. And as you know, obesity increases the complications of colorectal surgery. Obesity also is related to an increased risk of colorectal cancer. That is why I think that bariatric surgery, now I'm biased because I have dual fellowships. I think there's a very strong connection between bariatric surgery and colorectal surgery. They're very closely related. And I know most residents aren't really interested in bariatric surgery. I wasn't interested as a resident, but denying the fact that bariatric surgery not only cures comorbidities like diabetes and hypertension and metabolic syndrome, but also reduces the risk of having colorectal disease, for example, certain number of cancers, I think is undeniable today. You cannot deny it. And I personally feel like a lot more research should be done in Kuwait. For example, in Jabr, we published a meta-analysis. I believe it's the first surgical meta-analysis in Kuwait on the effect of bariatric surgery on colorectal cancer. And we found that there was a reduction. So there's an overall safety in the incidence of colorectal cancer in obese patients who've had bariatric surgery. So again, you'll see obesity a lot, and I just want to stress the importance of bariatric surgery. So numbers, the right colon, in terms of bleeding, now specifically bleeding, so the right colon is the source of bleeding in up to 90% of patients. Usually it's not from the left. The most common is actually the most common cause of brisk hematochezia. So massive lower GI bleed around 30 to 50% of the time. So if you get called to a patient, like a 70-year-old with a massive lower GI bleed, half of the time it's going to be a bleeding diverticulosis. It stops, the good news, it stops spontaneously in 75% of patients overall. And in 99% of patients who are transfused less than 4 units per day. So it's not a very deadly bleed. So the management, it's exactly like the management of any lower GI bleed. So I won't go into the details, but it's important, I think, for residents to know the algorithm. So ABCDs, resuscitate, resuscitate, resuscitate. And then you first have to diagnose to see what the bleeding is from. So usually you can get the diagnosis with a colonoscopy, if the patient is stable, of course. If a colonoscopy there's blood everywhere and they can't pinpoint the exact location or cause, you can then do a CT angio. The treatment we'll talk about now. So you can either conserve, as we said, and give blood if needed. There's endoscopic treatments, there's angiography, and the last resort is surgery. So, patient has lower GI bleed, you've stabilized the patient, and if you have a colorectal surgeon who can do advanced endoscopy, or if you have an endoscopist in your hospital, you call them, and if the patient is stable, they can have a colonoscopy. So a colonoscopy usually can detect if there's a bleeding diverticula, and there's different ways to treat it. A lot of studies have been done comparing them, and the study sample sizes are small, they have low power, but they're all effective methods. So you can either do a 4-quadrant submucosal injection, as you can see in the picture, of epinephrine. You can use bipolar coagulation. You can do banding, so very similar to how you band esophageal varices. And basically what you do is you evert the diverticulum. So you bring the diverticulum actually inside the mucosa and you put a band, and you can see by the picture. And then you can also use clips, as you can see in the picture there. So if you go in, let's say you're doing the colonoscopy, there's blood everywhere, you can identify the bleeder, but the patient is still stable, but still bleeding. The next thing you can do is CT angio. If they detect where the bleeding site is, you can do angiography. As you can see in this picture, so this is an angio done, and you can see there's an obvious bleed there. And again, you do it when you can identify the site, or if you try using the different modalities we talked about and you can't stop the bleed. So it can achieve hemostasis in the vast majority. However, there's a very high rebleeding rate. So surgical resection. If you tried the C-scope, you tried the angio, you tried to resuscitate, and patient is still unstable, what you do have to keep in mind is it's best if you identify which diverticula is bleeding beforehand, okay? In the past, they used to say you can do segmental resection. So you go and just remove the sigmoid or whatever. It's completely unacceptable. You cannot do this anymore. If you don't know where the bleeding is and the patient needs surgery, you can always do an intraoperative colonoscopy. It's very simple. You can do it, you identify where the bleeding is, and then you can chop off that bit. Subtotal colectomies are the last resort. Unfortunately, a lot of patients end up getting subtotal colectomies. This is not proper management. The best management is segmental colectomy. You remove the part that's bleeding. So patients who continue to bleed, and you still, even with an intra-op colonoscopy, you can't identify the source. Basically, these patients usually end up having a subtotal colectomy with an end ileostomy and a rectal stump. Most of these patients do not have an anastomosis. Number one, because they're quite old, and it's not very nice to live the final years of your life with an ileorectal anastomosis. There's very high morbidity and mortality. A third of these patients either die or have subsequent morbidity. The only advantage is the rebleeding rate is obviously zero because there's no more colon left. Okay, so this is the last, we've completed everything related to diverticular disease. The last story we'll talk about is Brock Lesnar. I'm sure if you haven't heard of Fidel Castro or the Van Halens, you must know Brock Lesnar. So this guy is a real champion. In 2002, he was the youngest WWE champion. So it was back when it was called the WWF. So he played, he was a wrestler. And then 2 years later, he turned into NFL. So he became a defensive tackle for the Minnesota Vikings. And then in 2005, he moved to Japan. He went into Japan Pro Wrestling, and he became the champion in that as well. And then in 2008, he played UFC. So he was into MMA, and he was the UFC heavyweight champion. So this guy he got all the championships you can think of in wrestling. However, in 2009, he had 2 attacks of diverticulitis. Simple, uncomplicated, and he had sigmoidectomy for that. Most people thought his career would be over. He thought that he would no longer be wrestling. However, lo and behold, 5 years later, in 2014 and again in 2019, he went back to wrestling and he became the WWE World Heavyweight Champion. So he's the only person in history to hold a UFC championship and a WWE World Championship and have diverticulitis at the same time. So lessons learned, never give up. You have to be like this mouse. You put on your helmet and you attack the cheese. And thank you very much for listening, Dr. Ali.
Yes, we're gonna put the questions now back again before we end. Or do you wanna say anything else before we start?
Me? I think I've said enough.
We'll put the questions again now.
Okay. So questions again. Which of the following patients generally does not require surgical intervention as a consequence of acute diverticulitis?
So meanwhile, the people put their answers in. You can have a look in the Q&A panel. A couple of our viewers posted some questions. You can have your pick.
Okay, answer live. Usually CRP will raise, yes. So CRP usually above 50 is the best blood test to do. This question was by Asrar. Simra Arif, will extensive colectomy not lead to short bowel syndrome because large segments of the colon? Now, short bowel syndrome is usually having less than 1 meter of small bowel. So as long as you don't touch the small bowel, the patient shouldn't have short bowel syndrome.
Okay, we're going to end the first poll.
Oof, and then Fahd Saleh wrote 3-paragraph question, longer than my presentation.
We're going to share the results of the
2 questions.
So most people answered the A for the question.
Yes, so this is a trick question. Now, as I said, this is a very trick question. I understand why you might think that a 35-year-old man with no history of diverticulitis. But, so I would, if I was an examiner, I would accept A, okay? But I think after this lecture, a 55-year-old woman with hypertension and diabetes will most likely be the patient not requiring surgical intervention. A 35-year-old man probably has his whole life ahead of him. If he gets one attack, and again, we said it is very common, if he gets one attack of diverticulitis at this age, most likely he will opt for elective surgery. So again, I would accept A, but diabetes is not considered a major immunosuppressant. So a 55-year-old woman with hypertension and diabetes, I wouldn't think that she would require surgical intervention.
Okay, for the next question.
So test with the highest diagnostic yield for detecting colovesical fistula. As I said, are they voting again?
Yes, they're voting right now.
Okay. So let's try to... Dr. Badr Shaban. He is the head of colorectal surgery at Jabr Hospital. So, do you prefer diverting colostomy or ileostomy after resection and anastomosis? Dr. Badr, I personally would prefer diverting colostomy for a simple reason. A lot of these patients come in with unprepped bowel if they have emergency surgery. So the advantage of diverting colostomy is you can, after you perform your anastomosis and bring out the stoma, you can have you can easily irrigate fluid through a Foley catheter inserted in the distal limb, and then you can wash out the anastomosis and really clean it up. I know there's no evidence for it, but in case there is an anastomotic leak, and again, there's no evidence that defunctioning actually reduces, as all of you know, the anastomotic leak. But in case there is an anastomotic leak, I think the leak sepsis, and abscess formation can greatly be reduced if that area is completely washed. So I would go for a diverting colostomy. Again, you would need to probably mobilize and bring down the splenic flexure to bring out diverting colostomy, but you can always go for a transverse defunctioning colostomy or an ileostomy, I think, if all else fails.
Okay, so we're gonna end the poll for the second question. You should see the results now.
Again, you're all wrong. So the highest diagnostic yield is actually cystoscopy. That's the least answer. Because in a so I'm not asking what test you would do. So I agree with everyone. If I was going to do a test, I would do CT. But the highest yield is actually for cystoscopy, but because you're actually seeing the fistula. I hope these questions don't come in the board exams.
For the third question.
Which of the following is not true of diverticular disease? It is more common in the US and Western Europe. A low fiber diet may predispose. It involves a sigmoid colon more than 90%. 60% of diverticulitis, 60% develop diverticulitis during their lifetime. It is the most common cause of massive lower GI bleed.
We'll end the poll now and should see the results.
Yes, finally, you passed. Everyone passed. So, as we said, only 4% of patients actually develop diverticulitis. 50-year-old presents with left lower quadrant pain, tenderness, fever. He's thought to have diverticulitis. There's moderate tenderness in the left lower quadrant. The ideal management is IV antibiotics, percutaneous drainage, CT-guided drainage, surgery, colonoscopy. If anyone answers colonoscopy, I will turn off the presentation and go shoot myself.
And the results are up.
Yes, excellent. Good. So either IV or oral, but yes, the idea is right. 8 people answered colonoscopy. I mentioned this in my lecture, so all of you should know this. What percent of people above 60 will have diverticulosis?
And ending the poll now.
Okay, excellent. Yes. So 60% at age 60 will have diverticulosis. Perfect.
Okay. You want to answer a couple questions from the Q&A?
Okay, there's still...
We're going to have more time.
Okay. So we talked about this answer, the one we talked about. Okay. Okay, so we'll read Fahd Saleh's question because I can't really summarize it. But how much time do we have?
We have time.
Okay. So Fahd Saleh asked 2 questions. First, he asked about mesalazine enemas. And again, they used to be used. So the guidelines, if you read the guidelines, there's weak evidence. But the ASCARs and the EAS both said that there's no evidence strong enough to prove that mesalazine in any form there's any advantage for its use during diverticulitis. And I can share it with you, Fahd, later. So Fahd says, even though a few studies recommended primary anastomosis over Hartmann's procedure, and this is what we talked about, what you deduce from these studies is that even though they recommended it for Hinchey 3 and 4, they excluded patients with hemodynamic instability or considered unstable. Thus, these patients in the studies are super selective, are on the better side of Hinchey 3, borderline Hinchey 2. Given this information, do you think that these studies can be implemented in real-life practice? In most Hinchey 3 and 4 cases, as almost always, are unstable active. What are your thoughts? And then he kindly cited these studies. So personally, as we said, in a patient who's unstable, there is absolutely no reason to take risk. Okay? Go in, do a Hartmann's, and come out. If you want to anastomose and a Hinchi 3. Again, this has to be a patient, and it's the surgeon's decision based on how well the patient is doing. If the patient is stable, you can go ahead and anastomose. I would do it personally. If there is absolutely any doubt regarding the anastomosis, bring out a diverting stoma. It's a very simple procedure to do. Diverting stoma is very simple to do. The patient knows that most of the time it's temporary. You can tell them it's temporary beforehand. And then if anything happens to the anastomosis, you have a stoma, you can then fix the anastomosis, treat it, wait it out, and then reverse it. Or everything heals well, you can just reverse the anastomosis 2 or 3 months later, and that's it. So you raise a very valid point, Fahad, and I agree. It's based on the discretion of the surgeon. You alone, during surgery, have to decide whether or not to anastomose or not. But I think that generally speaking today, you can get away with anastomosing a Hinchi 3. A Hinchi 4, if the patient is stable, maybe with a defunctioning stoma. An unstable patient, definitely no anastomosis. Fahad's question is so long, there's no link to click answer the question. We answered this. Badr Shaban is asking Fahad regarding your answer. Asking me, sorry. We deduced that you might take the option of resecting and anastomosis without diversion in selective patients. Yes, I would. In a certain number of patients, completely stable, as Fahad said, maybe very early on, Hinchi 3, borderline Hinchi 2, but in most patients, Hinchi 3 and Hinchi 4, if I was going to do an anastomosis, I would divert. I wouldn't take the risk at all. There's absolutely no reason to flex muscles in cases like these. Do the safest thing you can do, offer the patient the best treatment, and come out and to fight another day. How would you manage a patient with incidental finding of diverticulosis? The way you manage is you sit with the patient and tell them to live a normal life. Most important thing is to make sure you optimize their diet. And again, this is where dietitians play a very vital role. You need to have your dietitians available. It's a multidisciplinary approach. You need to tell them that they manage their diet, low red meats, high fibers. They need to increase their physical activity, reduce obesity, the risk factors that we talked about, in order to avoid complications of their diverticular disease in the future. Are we gonna answer any more questions?
It's up to you. I know we've spent a long time answering. I understand the questions keep coming in. Unfortunately, we can't answer them all.
There's like 12 waiting now, but I think we've answered most of them. Yeah, they're all important, but we answered most of them.
Unfortunately, I know you have a busy schedule, so we'll close the polls for the question. But we have one bonus questions you left for.
We have a bonus question. I added the question, so we didn't make it part of the original questions because the answer isn't really in my lecture, but it's a bonus question. If you answer this question, you won't get a prize, unfortunately, but deep down inside, you can know that you are an amazing person. Dr. Ali, can we put up the question, please?
Yes, coming up.
Again, it took me around half an hour to find the answer to this question. So when was diverticular disease first described? 1880, 1900, 1920, 1940, and 1960.
Okay, we'll end the poll and sharing the results.
Well done. The questions, the scientific questions, they answer wrong. But the most unscientific historical question, they answer right. But well done. I'm proud of you guys. It's correct. 1920. was the first described in a publication in 1920. Fatima al-Mu'min says, yay, mabruk. And whoever answered 1920, you are a very smart person.
I want to thank you, Dr. Suliman, for this wonderful lecture. It's been always a pleasure to have you with us. And I especially want to thank the viewers from coming in from all over the world. We really appreciate your support. I just want to remind everyone that this session is recorded and it will be uploaded to our platforms. It's available on our website, on our podcast, or available on Spotify and Apple Podcast. And you can register for our next session on gallbladder disease by Dr. Muhammad Jamal on Wednesday. You can follow us on Instagram and Twitter at SurgeQ8. You can just pull up your phone and put the camera on the QR code and take you right there. Once again, thank you, Dr. Suliman, and thank you, everybody.
Thank you, Ali. And I want to special thank you to all the surgical residents who are being deployed all around Kuwait to treat COVID patients. I think you're very brave, all of you, and we're all very proud of you and what you're doing.
Thank you.
Okay.
Okay. Thank you. Thank you for your time.
Yalla, have a good evening, everyone. Salam.
Salam.